Picture this: a woman is 67 years old, active, cheerful, wakes up at 6 a.m., walks 30 minutes every morning, cooks for her grandchildren on weekends. Her daughter finally convinces her to just do a full body checkup. She feels fine. She feels more than fine. 14 weeks later, that same woman is on her fourth specialist visit, taking 3 new medications, afraid to eat half the food she loves, and spending more time worrying about numbers on a report than actually living her life. She was not sick when she walked in. She might be now. This is not a story I invented. This is a pattern I have watched repeat itself so many times that I feel an obligation to talk about it openly today. I work specifically with adults over the age of 60, and my focus is on the relationship between aging, metabolism, and the decisions we make in the name of prevention. Here is what I keep seeing. Well-meaning people, people who are walking, eating right, staying social, they go for a routine checkup, and they come out the other side with a new identity. Not a healthy person, a patient. That shift has a mechanism, and it can begin with something as simple as one extra blood test ordered on a Tuesday afternoon. Today, I'm going to walk you through 5 common healthy habits that the medical system quietly recommends for people over 60, but which for many people in that age group may carry more risk than benefit. Stay with me through all 5. Number 3 will change how you think about something you were told was absolutely essential. And Number 1 is the one that almost nobody is questioning right now, even though it affects crores of people every year. Before we begin, drop your city in the comments. I want to know where you are watching from. It matters to me. But first, one concept. I call it the quality first lens. When you are 45, preventing a future disease 20 years away makes perfect sense. You treat something now to protect yourself later. The math works. After 60, something fundamental changes, the goal shifts. Now the question is not just how long, it is how well. And many of the interventions designed for a 45-year-old body carry a very different cost-benefit calculation in a 65-year-old body. Keep that lens with you through every single point to routine full-body CT scans in asymptomatic adults over 60. This one sounds responsible. It sounds thorough. Your whole body scanned. Anything that might be hiding, found. Here is what the brochure does not tell you. A full-body CT scan in a person with no symptoms has an incidental finding rate of nearly 40%. That means in almost half the scans, something is found. Not because it is causing harm, but simply because the scanner is sensitive enough to see it. A small spot on a kidney, a minor shadow near the pancreas, a minor variation in a lymph node. Each of these findings now requires a follow-up, then another scan, then possibly a biopsy. Each step carries its own risk, its own anxiety, and its own momentum. The radiation exposure from a single CT scan is equivalent to approximately 200 chest X-rays. In a person over 60, who may receive several such scans across follow-up visits, that exposure accumulates. What to ask instead? Do I have a specific symptom that this scan is meant to investigate? If the answer is no, the conversation should stop there. Automatic statin prescriptions based on cholesterol numbers alone. Statins are one of the most prescribed medications in the world. For people who have already had a cardiac event, a heart attack, a stroke, they have shown real benefit. But here is where it gets complicated. For adults over 70 with no history of cardiac events, no diabetes, and no symptoms, the picture is far less clear. Multiple recent analyses have found that for this specific group, primary prevention, meaning we are trying to prevent a first event, the absolute risk reduction from statins is often less than 1% over 5 years. At the same time, statins in older adults carry real side effects. Muscle pain that can severely limit activity, cognitive fogging that many patients describe but are dismissed on, and fatigue that quietly reduces quality of life. When a 72-year-old stops walking because their legs ache, and the aching is from the medication meant to protect their heart, that is a harm the prescription did not disclose. What to ask? What is my personal absolute risk reduction from this medication? Not the relative risk, the absolute risk. And what are the documented side effect rates in people my age specifically? Annual HbA1c monitoring that leads to automatic prediabetes labeling. This is the one that surprises people, because it sounds like pure vigilance. Here is the issue. As the human body ages naturally past 60, HbA1c, the blood sugar marker, tends to rise slightly. This is a normal part of aging metabolism, not necessarily a pathological signal, but reference ranges on lab reports are often not age-adjusted. A reading of 5.8 in a 68-year-old is immediately flagged as pre-diabetic, triggering dietary restrictions, anxiety, sometimes medication, for a number that may be entirely normal for that person's age. The label pre-diabetic has been shown in research to cause significant psychological harm and behavioral disruption, often with no corresponding improvement in actual health outcomes. What to ask? Are these reference ranges age-adjusted? What is the actual trajectory of my readings over time, not just today's snapshot? Routine thyroid screening in older women without symptoms. Low thyroid function is genuinely common in older women. But here is what the research shows that most follow-up conversations don't include. Mild hypothyroidism in adults over 65, what is called subclinical hypothyroidism, often requires no treatment at all. Studies including data from over 70,000 patients have found that in many cases, subclinical hypothyroidism in older adults does not increase mortality, does not significantly impair function, and in a notable proportion of patients, resolves on its own within 12 months. Routine aggressive follow-up of incidental findings in imaging. This is the one almost nobody is questioning. You go in for an MRI of your knee or a scan of your lower back, and on the edge of the image the radiologist notes an incidental finding, something unrelated to what you came in for. In adults over 65, incidental findings on imaging occur in over 50% of scans. Small adrenal nodules, minor liver lesions, pulmonary nodules. The vast majority of these will never cause any problem. Most are benign, most would never grow or spread or affect a single day of life, but the word finding triggers the system. Follow-up scans are scheduled. Anxiety becomes chronic. Some patients undergo biopsies for nodules that guidelines themselves classify as almost certainly benign. I want to tell you about Ramesh. Ramesh is 71. He came in for a routine back scan after mild discomfort from gardening. The scan showed a small adrenal nodule, a completely incidental finding. Ramesh was referred, then rescanned, then referred again. 18 months later, the nodule had not changed at all, but Ramesh had. He had stopped gardening, he had stopped his evening walks. He spent those 18 months in a state of quiet terror, waiting for news about a finding that will almost certainly never affect his health. When I spoke with him, he said, "I went in for a backache and came out with a cloud over my head. That cloud is real, and it has a medical term. It is called the psychological burden of incidental findings. It is documented, it is measurable, and it is almost never discussed before the scan that creates it."